moment, everything in this space feels incredibly scary and hard to grasp because the landscape is changing so quickly. I'm part of a group called the Sickle Cell Disease Partnership, and we work very closely with Congress and US senators to be able to, again, reignite this conversations of like, you can't leave this community in shambles, especially when in the prior administration, when the president was the president of the United States, sickle cell was one of those causes that was near and dear to him and that he wanted to champion. But right now, it's a very unsettling space for CBO organizations and for patient advocates because what we're hearing is that next year, funding is going to be cut for all of the work that as CBO leaders we're trying to do in the space. And so it's kind of like we're playing a race against time, hopeful that some of our initiatives will continue, but will be significantly scaled back, which means we can't help as many people impacted by sickle cell disease and their caregiver community in the way we would like, because without funding, we can't do our work. We just can't. Because for us, you really cannot leave patients that are already traumatized by this system further broken by just pulling like research funding.
This is Genetics for Healthcare, a podcast for patients.
Today we have Wumi, Bakare, and Christelle Salomon, sickle cell warriors and host of Through the Genes podcast. Thank you guys both for being a guest on Genetics for Healthcare.
We're so happy to be here. It's such a pleasure to join you today.
Super excited. Can't wait for our conversation.
So tell me, how'd you guys come together to start creating Through the Genes podcast, and what's the mission of your show?
So in 2022, I was blessed to have been brought on board a project called the Democratizing Education for Sickle Cell Disease Gene Therapy Project, which was curated by the Bonham lad, Vince Bonham, who was the former acting deputy director of the National Human Genome Research Institute. And that entire project was developed because at the time there were no toolkits for patients on gene therapy. And so it brought together a group of 60 stakeholders from caregivers to patients, nurse practitioners, biotech and pharma individuals, as well as clinicians and researchers for us to work as a collective group over a period of 6 months during the pandemic to develop this toolkit. And when the toolkit was developed, I had a conversation with Mr. Bonham, who's like a mentor to me. And I said, well, then the question then goes, we've created this incredible work. How do we disseminate this information? And he was like, okay, well, we can reach out to the CBOs. And I said, that's all great and dandy, but the information is very clinically like healthcare heavy in terms of like information. We needed to simplify this for the community. And so I pitched the treatment for what is now Through the Genes, which is let's develop the podcast that is patient-led, patient-driven, where we have conversations with the clinicians that were part of this development process. And we share in layman's terms what the risks, the benefits, and the limitations of cell and gene-based therapies were. And when I pitched the treatment initially, in all sincerity, I was never supposed to be a host of the show. I was just supposed to be the executive producer behind the scenes. And he saw something in me that I genuinely didn't see in myself. And so we got together and the NHGRI commissioned us for 3 episodes. They wanted to see what patients could do because in the history of the NIH, they have never had a public-facing show that were led by people that weren't MDs. So they were literally just wishing and hoping we would do our best. And after we delivered our first 3 episodes, they commissioned us for an additional 3 episodes because they didn't quite see the vision, but I think when you see what we were able to do on that show, it became very apparent that Through the Genes was going to be a blueprint for conversations around cell and gene therapy in the sickle cell space. So that's a little bit of our origin story. And doing season 1 was incredibly impactful and fulfilling. But really and truly, I think for me, what made me super excited was the feedback from community. Because oftentimes in the sickle cell space, things are developed for us without us. And this was the first time there was intentionality behind creating something for patients, by patients, with patients. And season one was great because you had a dichotomy. You had Wumi Bakare, who had experienced stem cell transplant and it was a success. You had Dima Hendricks, who had experienced the gene therapy protocol, but due to a blood clot in her heart, she had to be dropped from the study. So you have someone who is like adamant, this worked for me. I genuinely think if your sickle cell journey is getting a little bit more complicated, then maybe you should consider transformative therapies. And my co-host Dima, who was like, absolutely not. I'm still in full support of disease modifying therapies. And so with season one, we brought both of those contrasting views because that's the reality of the sickle cell community. Not everyone strongly believes in the idea of gene therapy and stem cell transplant. And then season two, we brought on the fantastic Christelle Salomon. And I loved Christelle because the minute our show came out, she was a huge champion for us. She had her weekly reviews on our show talking about, things. And for her, in her journey, she was still, I want to say you were only a year post transplant. So for her, it was like, these were the things I would have needed to know prior to my journey. But now that it's here, hey guys, you guys need to tap in. And so it made organic sense that in season two, we brought Christelle on because I'll let her share about her story, but Christelle brings a wealth of research, knowledge, patient experience, medical training. And so she offers a really well-rounded perspective on the show that helps patient understand the more scientific information.
So, Christelle, I'll ask you. You work for the University of California, San Francisco, UCSF, the Sickle Cell Center of Excellence. So you were a fan of the show, and now you are a prominent voice on the show. When you're doing the show, like, who are you guys speaking to? Because obviously you're reaching patients, but you're reaching people like myself who are trying to learn and to become an advocate, healthcare providers. But how's that message gone out? Who's tuning into the show, and what's been the feedback from your listeners?
Yeah, that's such a great question. And I love working with Wumi on this podcast because, she said that she originally thought she was going to be the executive producer. And you can see that mind in her as we think about the podcast. She's like, who are we targeting? How are we going to get this out? She's very meticulous about planning. What is the point of this podcast? Who are we trying to help? And what is the actual help that's going to come at the end? And so it's a great thing that you brought up that question. And I think that, everyone is the wrong answer, but the podcast does intentionally try to meet multiple audiences where they're at. And so first and foremost, the goal is to reach patients. The goal is to reach patients and equip them with the resources that they need to make an informed decision. And I remember when we alluded to this, I was looking up transplant options. I thought I was too old. I was 28 at the time. And so I really had to reshape the framework that from which I was looking at transplant and transformative therapies and do a deep dive for myself. And an in a season where I was in medical school and also not receiving what I thought was the most accurate, well-rounded information from the providers that I had, I really had to do a lot of digging. And the thing that I love about this podcast, so many things, but the very first thing is that it gives you an inside look. I think there's something different about reading in a pamphlet about what a clinical trial is like. There's something about reading an informational website that tells you what do you expect during the treatment versus hearing someone's lived experience, hearing someone say, this is what I went through. And I would say, even as prepared as I was going into transplant, there were things that I never knew could happen. And now that I'm listening to the podcast, I'm like, this would have been so helpful. And I love the way Wumi and I met because we met online, and it not only does the podcast reach patients, but it does provide a sense of community. I think Wumi has very well articulated on different platforms that there isn't a community, a place that's home for people who have undergone transformative therapy and are now on the other side. And so I remember feeling very alone and isolated. And I'm like, I don't know if I'm a warrior anymore. Um, I don't know other people who've gone through this besides like one person that I no longer like. I met her once and that was like over a decade ago. And so I really didn't have anyone to connect with and talk about the journey. I had a few other cancer patient friends, but meeting Wumi online gave me that sense of community. Oh, wow, someone else with sickle cell disease has been through this. And so we hope to reach patients not only to empower them, but to give them a sense of community. And at the same time, I've already talked about my conversations with providers and feeling like I had to do a lot of the research on my own. And I think it's not any no hard feelings towards providers or blame towards them, but the system just doesn't prepare providers. I was in medical school and I learned hardly anything about sickle cell disease, let alone any of the treatment options. But I've learned about other diseases that are much less prevalent. And we learned about clinical trial options. We learned about all these things, like how to use an ECMO machine. I was like, do we need this right now? I'm just trying to pass my board exams. So I think there's a huge discrepancy in sickle cell education. And I think it bleeds down throughout the provider training from a med student to a resident to a specialist. And so I really hope that providers, medical students, people who are interested in learning about patient experiences can walk away when they go to talk to their patient about transformative therapy. They have an idea of what that lived experience is like. They're not going to regurgitate a textbook to their patient. They're going to be able to share and empathize and see the warrior for who they are. And I think that really is what makes a difference. We're not looking for providers to know absolutely everything. We're looking for them to see us and to say, I don't know when they don't know, but let's figure it out together. And I think that Through the Genes podcast is an awesome resource to really get not only the practical and scientific information, clinical information, but that lived experience that will help you connect with your patient a lot better. And I think we're funny. I think we're entertaining, and so I think this is a podcast that's generally listenable by the average person. And if we could get some buy-in from just the lay community about sickle cell and get people to empathize with our experience and see how hard it's been, I think that will be really powerful in moving the needle. So I know I took a little bit of a circuitous route to answer that question, but hope it makes sense.
Very robust, and I appreciate that information because this is kind of my mission, very aligned with you guys' mission for your podcast, is because we really want to reach the lay audience, the decidedly non-medical people, and you guys have had deeply personal stories that you bring to your podcast, and that's the power of story, hearing directly, first person from someone who's gone through something. But Wumi, can you share like a pivotal moment of your health journey that fundamentally shaped what you're doing today, your approach to advocacy and the work you're doing?
Sure. I'm going to reference two stories, but they tie into one another. So by origin, I'm born and bred in Lagos, Nigeria. Spent most of my childhood there, and then came to the U.S. at 15 for college. And after I graduated, I decided that I wanted to move back to my home country to start my own PR agency, which I did. Circa 2 years into moving back to my home country, I had a port placement, which for patients that have cancer or other blood diseases that require frequent blood draws, a port is inserted in your chest, and it's kind of how they access your vein. And I took my port. It was done in the U.S., but I moved back to Nigeria, and I still had my port placement. And my hematologist was this incredibly gracious Mexican hematologist, and he was like, in your home country, they might not have access to all of these port access lines. So I'm going to give you a pack of like 10 to take with you, because all through navigating sickle cell from a young age, my veins are not it. They look juicy, but they are going to give you absolutely nothing. So I got back to Nigeria, and I had what I felt was a vaso-occlusive crisis coupled with malaria. And they couldn't get access to my veins. And the doctor didn't tell me that she went home and watched a YouTube video about how to access a port. But she then used what she thought she learned from YouTube and accessed my port. And at the moment, when, like, if you have a port, once they go in, you oftentimes can tell when they are in the port because you should taste the coolness of the fluid, and that's it. And she went in and I kept saying, I don't think you're in. And she was like, well, the needle isn't sticking out. I think it's fine. Fast forward to 2 months later, I had dropped, I'm fairly on the petite, skinnier side. I had lost about 35 pounds. I was in our local hospital in Nigeria. I had developed an infection in my port, but in Nigeria, I was wrongly diagnosed. They thought I was having kidney issues. Um, when I say it was the most horrifying experience of my life, for people to understand that every day I prayed for death because I was in a room with 12 additional patients. We were all sharing two oxygen tanks, and almost every week another patient passed, and I just kept saying, I know one day death is going to come for me. That was how broken I was. Keep in mind, still under a wrong diagnosis. Thankful to my mom and dad who worked incredibly hard to give me a relatively normal life. I got flown to London because my health was escalating really quickly. And when I got to London and I showed them the medical records, it was then we found out that I was given the x-rays of a 58-year-old woman, was given as mine, which it wasn't. And I didn't have any issues with my kidneys. What was wrong was I had an infected port, that the infection had then traveled to my bloodstream. So it wasn't just malaria, it wasn't a kidney issue. Instead, it was a wrong port access process that triggered, again, an infection because it wasn't properly sanitized. And I remember being in London and the provider said, I've never seen a port that full of gangrene to that capacity before, that they had to put it in a jar. And he was like, I want my students to study this because we've just never seen this. I share that story because for me, two things became apparent. One, a country that is my home and that I loved didn't have the infrastructure to care for me in the way I needed. And two, if I didn't have the privilege of having patients who could send me abroad for additional health care, I would most certainly be 6 feet under today. So that happened, and I share that because it helps you highlight that my global experience and my lived experience are able to highlight the important health disparities that exist from continent to continent when it comes to sickle cell care. And another part of my story was, again, the way I'm in the US now. I came in 2015, 2-week vacation. I was coming to Seattle to see my brother who worked at Amazon. Flight from Amsterdam to Seattle, had a vaso-occlusive crisis. Arrived, EMS took me to the University of Washington Medical Center. Here I am as Wumi Bakare thinking, it's a VOC. I will be in the hospital tops 7 days. Fast forward, I was in there 6 months. It took 4 months for them to diagnose that I had Mycobacterium avium complex, which is an infection you cannot catch in the US or the UK, just in third world developing countries. So I caught it again in my home of Nigeria. And it was an infection that started in my lungs and then transitioned to my liver, my kidneys, my bloodstream. And the treatment for that was 24 months in hospital. So, because it takes 24 months and 5 different types of antibiotics to treat Mycobacterium avium complex. The people they tend to see with MAC are patients with HIV, not sickle cell. And that little origin story highlights again another two things. My home country, which I love so much, was not the right setting for a patient like me. And two, if we did not have the resources and I couldn't have made that summer vacation trip, for sure, by all accounts, I should be dead by now. But the miracle of life, and I always say that my life is honestly a pain into purpose testimony, is that the beauty of that was I then was classified as sick enough to meet the eligibility criteria for transplant.
While you were in the hospital there at University of Washington during those
Exactly.
months.
So if I wasn't that sick, that critically ill, I probably wouldn't have met the eligibility criteria to qualify for a transplant. So life has a very interesting and sometimes incredibly traumatic way of working. But in my story, it has been one that all of my lived experience informs the work I do today. All of the work I'm doing in this space is I'm grateful to America for the healthcare. I'm grateful to the community I've built, but I owe the patients in my home country who don't have my privilege, who don't have the ability to leave and go to another country to get better healthcare. I owe them that much to take my learnings and my influence and my connections back home and lean on pharma to develop other ways of being able to deliver gene therapy to my home country that has one of the highest patient populations in the world with 4 million patients. I mean, if you compare 120,000 in the US to 4 million, there are too many areas for you not to see that it's an overwhelming patient population in Nigeria. But these protocols, like stem cell transplant, is only available in my home country in three states out of 36. And again, we don't have quality insurance. So in Nigeria, most of our healthcare we pay out of pocket. It's a different beast when it comes to dealing with healthcare in my home country, but it's a job that I wear with pride. And it's also, I genuinely believe that that is my life's purpose and meaning, is that God wanted me to go through all of those things, not only to build my empathy level and my resilience as an individual, but so that I recognize that I had the option to leave and other people don't have that option. So I need to go back to where my story all started.
Yeah, I'm a believer that what happens to us in life has to happen to us to move us to a place where we're purposed to do something that no one else has been created, born, or can do. Like we live this life as an N of one. Christelle, you mentioned you were in medical school. You aspired to be a physician, medical doctor. How has sickle cell impacted your journey?
Similar to what Wumi said, like, you know, life doesn't always go the way you plan or think or want. But God is so good that He orchestrates everything for purpose. Like everything, He means it for good for us. And so even the parts that where I was hurt or things didn't go as well, I know I'm here right now for a reason where I'm supposed to be. And so sickle cell, it's twofold, right? It shaped my desire to go into medicine. I think if I didn't have sickle cell disease, I would probably be a third grade teacher somewhere, or I don't know what else I would do, but I wouldn't sign up for med school, that's for sure. Um, and I remember feeling that feeling when my doctor finally sat me down in Boston. He was great. I was 10 years old, and he said, what is sickle cell? And I was like, I don't know, red blood cells, oxygen. And I just looked at him. I was like, right? Isn't that close enough? And he's like, yeah, you're around there, but I need you to know. I need you to know what it is. I need you to know your medical care. I need you to be able to show up somewhere and take care of yourself. I need you to be able to advocate for yourself. And we're starting now. So every time I see you, we're going to talk about what you know. And he would test me. The next time he'd be like, okay, so what's this and what's that? And I remember it came a point where I didn't need my parents to go to the hospital. I was very privileged. I had an amazing care team and an amazing doctor who made sure I was educated. And so I felt excited about the science of medicine, and I felt excited about the art of medicine while in the hospital. Like the doctors are doing rounds and talking about all these different things, and I'm like, what's that, what's this? And they're taking their time to explain it to me. So it really created a curiosity in me about medicine. And I just remember thinking, if I could make another patient feel the way my provider made me feel, like how awesome would that be? And so I went into undergrad fully planning to go to med school. Had a lot of challenges in undergrad with being sick, taking time off, missing a lot of school. But that was the norm. that was the norm for life. You missed out on things when you had sickle cell. And so it didn't deter me. And so when I got to medical school, I would say my health between college and medical school was gradually worsening every single year. And that was what prompted me to move to California so I could avoid the cold and see if I could, make my life a little bit easier. Um, and that's not what happened. My disease just kept getting worse. And I got to a point in grad school and med school where I had pain every single day. It wasn't I'll just take some pain meds and stay home for a couple days. Um, I was just constantly in pain, and I didn't have access to a sickle cell specialist. I struggled to get the care I needed at hospitals, so I just avoided going because I didn't want people judging me or making my life harder while I'm there. And I'm like, you know what? I'm just gonna deal with this on my own. And so med school, I really put my head down and tried to get through, but it was so hard with the rigors of med school and the need to be excellent while you're there. And I just felt like I was giving the nothing that I had to med school, and there was nothing left for me. I was in the complete negative. And it was one final like straw that broke the camel's back where I really had to ask myself, can I reasonably be a doctor and continue with this training while having this disease eat away at every part of me? I was paying someone to do my hair. I was struggling to go grocery shopping. My room was always a mess. Like, I was a mess. I just couldn't take care of myself. And all I had energy for was, okay, I gotta study so I can pass this test. And I decided one final season, I was like, okay, it's 2 weeks before my finals. If I go to the hospital now, maybe I can get what I need to just get better enough to make it through my exams. I was tired of having to study for last semester's exam and this semester. It was exhausting. And so I went to the hospital, and that was the most demoralizing experience. And I've had many, the most demoralizing of all of them, especially having gone through like the training of how to conduct a medical history taking, how to approach a patient, having seen what questions to be asking, and to show up to a hospital, have no one ask me any questions, have people make assumptions that they have pulled out of thin air, that when I ask them, where have you come up with, how did you get to this conclusion, have nothing to say to me because they made it up. And so I just got to that point where I just was so tired of being accused and not getting what I need. They didn't give me the pain meds I needed, accused me of being a drug seeker, accused me of taking my own meds, accused me of taking other drugs, substances, and then didn't want to refer me out to a hematologist, didn't want to talk to anyone or consult anyone on their team. And I just felt like, you know what? The system hates me. It doesn't care for me. And I'm trying so hard to be part of a system that doesn't care if I'm here or if I die. And that really broke me. And I just, I knew I couldn't keep going on like that. Not to mention that it was hard to get the accommodations I needed at school. I just felt like I was constantly fighting to stay afloat. And so that's when I started looking into transformative therapy options. I took a leave of absence and really I really asked myself, if there is no Christelle Salomon, can there be a Dr. Salomon? And that's when I knew I really had to prioritize this journey. And that journey was hard enough on its own. Many knows it's hard to get the medical system to see my suffering as something worth intervening for. And I'm grateful to Dr. Walters. I'm grateful to the team that gave me the transplant, because that was the first place in many years, like since my pediatric care. So that had been at least 6 years where I felt seen and cared for as a person. And I know there have been doctors who care about me, and they're like, you're doing so well, you're in medical school, you just have to push through, and you don't need the transplant now. And I know it came from a place of caring for me and not wanting to see me hurt, but it completely lacked a recognition of my suffering right then and there. And so that has really shaped the lens through which I look at medical training and think about medical training. And I ended up not going back to medical school because I was being forced to go back on a timeline where I was immunocompromised in a wheelchair and had no good care available to me in Southern California. And I just decided again, there's no Christelle Solomon, there's no Dr. Solomon. And so I'm grateful where I am now, 3 years post transplant. I don't have the degree I thought I would. I don't practice medicine right now, and for the first year post transplant, it really broke me because I feel like I spent so much energy. I gave up so much to try to be a doctor, and then here I am, not one. But I'm so grateful for where I am and the fact that I get to do work that's meaningful to me. And I don't have to feel like I'm choosing between my career and my existence. I'm really grateful for that. And so that's a little story.
Your stories are so powerful and important, especially for those who are fighting and who still maintain hope, even though they're judged, they're criticized, and there's so many other forces working against them. Um, let alone being a black man or woman in the world, and the things that you just encounter every day. Let's talk about racism in healthcare. Okay,
Let's talk about it.
so for whatever reason, this is not a politically popular topic in the U.S., but this ain't the U.S.'s show. This is Genetics for Healthcare. So I spoke to Victoria Gray, who was the first sickle cell patient ever treated with CAR T therapy, CRISPR therapy. And, thank goodness, her experience was phenomenal. She has been since 2020 completely cured, no symptoms of sickle cell. But the New England Journal of Medicine published a study in 2020 that said discrimination is an issue encountered by many sickle cell disease patients across the globe during their lifetime. And in this piece that they published in 2020, Power, Hayes, and McCann expressed that there may be no population of patients whose healthcare and outcomes are more affected by racism than those with sickle cell disease. They gave examples in that paper during the 1970s that many African Americans, in Black people in America, were deprived of jobs, educational opportunities, marriage licenses, and life insurance, health insurance in the US if they carried sickle cell trait, they had it in their family. They also talked about in terms of screening, sickle cell screening. Sickle cell disease patients had to meet uh, prevalence thresholds not demanded of other rare conditions. I believe, Christelle, you just spoke about that. They had to meet those thresholds before newborn screening became implemented widely to save the lives of, Black babies, and that was eventually made universal. Universal testing in England in 2004. Not done. In a paper written in the journal titled Biology of Blood and Marrow Transplantation, a publication supported by the American Society of Transplantation and Cellular Therapy. In 2020, Cho et al., lead author, conducted a study examining the motivations and decision-making processes of enrollees and decliners of high-risk trials for sickle cell disease. And of the 26 sickle cell patients interviewed, the majority reported that negative interactions with healthcare providers. These experiences were so bad that many of the individuals had chosen to avoid hospitals, even during significant pain crisis. My question for both of you is this type of implicit bias still an issue when it comes to sickle cell warriors getting the therapy that they need? Is it getting better? Are we moving past it now that we have many different or more therapies available to treat?
In healthcare, there will always be implicit bias. I strongly believe that. I think is from medical school that trickles of that implicit bias is sprinkled. And then when you become a full clinician, There's other, because as human beings, there's something called groupthink, right? And even in ER systems, I've seen examples of a compassionate nurse practitioner who is met with a provider who has just seen my illness before they've seen Wumi and has assumed everything horrible about me as the individual. And I start to notice that his decision making starts to sway the nurse's decision making, which is why I say implicit bias will continue to go on. Now, when it comes to conversations around cell and gene therapy, there is something that we have noticed as patients, which is that if you are an adult patient, oftentimes your provider is not going to tell you what your options are in terms of treatment. They will offer you the standard of care treatment, which is hydroxyurea, which I have to preface by saying, if you didn't know, hydroxyurea was never made for sickle cell. It was made for cancer. And they just found out when they were treating a patient who had cancer and sickle cell that it also helped the management of her sickle cell disease, which is why it became the standard of care treatment. To me, that is wild, is that they couldn't even develop a standard of care treatment that wasn't specific to our disease. It had to be something determined for something else that they then use to treat sickle cell disease. And in cell and gene therapy, what's happening is, because providers aren't even initiating that conversation with adult patients, a lot of patients in rural America don't even know it's an option for them. Even with CGT, one of the things we're also noticing is that this implicit bias and this systemic racism in healthcare also carries over on the other side of a transformative therapy. We have friends in this space who are still dealing with reproductive issues post transplant gene therapy. I myself, I'm still dealing with chronic pain. Unfortunately for me, it isn't something I've been able to completely rid of, but I will say, in comparison with my sickle cell vaso-occlusive crises, I will say this is I can live with this pain all the time. A 5 out of 10 was my baseline where I lived with sickle cell disease. So this level of pain feels, for lack of a better word, familiar to me. But even on the other side of a transformative therapy, and Christelle knows this story, is I've been met with resistance. I've been in the ER where I had influenza that was also the stress on my body was triggering pain. And a nurse practitioner said, because you have been through a transplant, I'm sending you home on Tylenol and I'm stopping your entire pain plan. And she went as far as going in the system and deleting my pain plan, because the assumption was I'd had a transplant and pain should be a conversation of the past. She thought I was drug seeking. So unfortunately, even though we have been through gene therapy and transplant, it doesn't negate that when we go into healthcare spaces, particularly the ER, we feel safe as patients. For me, I'd rather stay at home and suffer with COVID for a whole entire week than go into an ER.
This is not an attack on your character. These are just facts. Okay. Everyone has biases. Whether or not they have to do with race is a totally different story. But the world in which we grow up in, the things that we watch, the patterns that we learn, they shape the lens through which we do life. That's just how it works. So biases exist. And I think what happens around these conversations around biases and racism, people get all like nervous. Like, it's not me. Like, no, it's everybody. Like, no one is excluded. There is no perfect person who doesn't have a bias. As a Black person, I have biases for XYZ number of things, right? And not all biases are bad, but understanding the consequences of your biases is what's important. And that's why we talk about it. Let's just get on the same page. And so I think what happens is that in medicine and in healthcare fields, and I think even in professional spaces, when talking about biases, people get offended. Like, well, I didn't do that. Well, I'm not racist. I'm not. No one's saying you're anything. But if you have the resistance to even hearing the story, then there's something worth unpacking. There's something worth discovering and understanding. Why do I feel so off about this? Why do I feel so resistant to this conversation? And you may find that you are offended. You feel like someone's attacking you. Well, we're not trying to attack you, right? So I think there are ways to really go about understanding for yourself where your biases stand, without it being some moral like dilemma within yourself. Like, let's just clear that up. And if you do find there's a moral dilemma, great. Now you have something to work on. You can't fix what you don't know. And I think most providers don't walk into this space like, oh gosh darn it, I can't wait to hurt people. Most of them come with this perspective of wanting to help their patients. But if your bias is preventing you from doing that, wouldn't it be worth discovering how to rewire those patterns of thinking?
You mentioned Vince Bonham, who is your mentor.
Yes.
At the time was the acting deputy director of the National Human Genome Research Institute. Since that time, he's been placed on administrative leave by the current White House administration. Recently, $800 million in research funding to the National Institutes of Health has been lost. And even when you go to the website that you mentioned, Democratizing Education for Sickle Cell Disease Gene Therapy Project, the website is flagged that it's not being, maintained and updated. It's still up, so it's still good information there. We'll have the link on the episode page on Genetics for Healthcare and all those platforms. You do a lot of work with industry to help bring that patient voice to their efforts, whether it is research and commercialization. What are you hearing from your supporters and those companies who have enlisted your services, whether it's NIH, pharma doing research? If there's no financial incentive in the future, all right, they will stop investing. But we're so close with curative therapies and interventions for them to stop investing. What are you hearing?
At the moment, everything in this space feels incredibly scary and hard to grasp because the landscape is changing so quickly. I'm part of a group called the Sickle Cell Disease Partnership, and we work very closely with Congress and U.S. senators to be able to again reignite this conversations of like you can't leave this community in shambles, especially when in the prior administration, when the president was the president of the United States, sickle cell was one of those causes that was near and dear to him and that he wanted to champion. But right now, it's a very unsettling space for CBO organizations and for patient advocates because what we're hearing is that next year, funding is going to be cut for all of the work that as CBO leaders we're trying to do in the space. And so it's kind of like we're playing a race against time, hopeful that some of our initiatives will continue, but will be significantly scaled back, which means we can't help as many people impacted by sickle cell disease and their caregiver community in the way we would like, because without funding, we can't do our work. We just can't. And with Vince Bonham leaving NIH, I will say this. Mr. B is probably one of the most resilient, passionate, but incredibly smart humans. And I can't wait to see. I know some of what is next in his career. I cannot wait for the world to be up to date on what's next for him. But the work that he has started has had a trickle down effect. A lot of the work he did with the Democratizing Project not only led to this podcast, but Christelle and I have created our own research initiative in partnership with UCSF. And we're working with 16 astounding providers, everyone from MGH to VCU, across like institutions across the country that are facilitating these clinical trials for transformative therapies. Because for us, you really cannot leave patients that are already traumatized by this system further broken by just pulling like research funding, especially when people didn't really have time to work out an alternate strategy of how we can continue. Because for me, I think 2026, even though there's a sickle cell renaissance that happened between 2023 and now with the announcement of the FDA approved gene therapy, 2026 will be a case study on how we pivot and we adapt to these significant changes. We're losing people, even on the pharmaceutical side. I can tell you in the last month, we have lost some really fantastic people working behind the scenes. And that makes me nervous. It makes me nervous because this community will always need help. But if we now don't have ways in which to get funding to execute our programming to serve this community, we're going to have to think of other ways to alter our fundraising strategies. But I also think sometimes necessity is the mother of invention. If we aren't put in these situations, we're not going to find alternative ways to find. And I've always been a strong believer, and maybe because I come from a PR background working with lifestyle and consumer brands, I've always said, I don't think pharma should be our only source of funds. I genuinely don't think so. I think we need to diversify our list of those we seek funding and grants from into, the Bill and Gates Foundation and other entities who their sole job is to provide resources to these CBO organizations that are doing the grassroots kind of roll up your sleeve type of work. And so I'm hopeful that in 2026 that not only with this community that has faced so many glass ceilings in the past, not only will we adapt, but we will also kind of figure out a way to still serve, but in a more less financially tasking way, if that makes sense. And I think the pandemic really showed us that like work never stops. We as human beings, we always find a way to adapt to new and upcoming changes in the space. So I hope that answers the question.
Okay, real quick. I know you got to go, Christelle, but I want to ask you before you leave the last question. What are 3 practical tips to help sickle cell warriors advocate and gain access for themselves to the different therapies that are available now to treat sickle cell disease?
The first tip is be open. And I mean that in a way of understand what is it that you want out of life, and what is it that these options stand to offer for you. You don't have to say yes to everything. In fact, you should not. But I think you should at least give everything a peek. Give everything a peek, and you can decide for yourself if it's off the table or on the table or in the parking lot for later. That's one thing. Be open and understand what you want out of life. The second one is to ask lots of questions and ask them again and ask them to multiple people, because one person might give you an answer and you might find an answer that's different from someone else. I think it's important to ask and ask and ask, and the right people will be willing to answer those questions again, be willing to meet you at your area of most concern when it comes to doing high risk treatments, not even just transformative therapy, but if you're nervous about trying a new drug, they should be willing to answer your question again. Don't ever feel like you can't ask a question enough. So that's the first 2. The third is to do your own research. And I hesitate to say this because I really don't feel like it's our job. It's not, but it is. And if no one else is gonna do it for yourself. And so there have been many a times I have gone to the expert with a thing and it doesn't match up with the expertise that I am reading from trusted sources. Don't do research anywhere. So research wisely. If you're not sure about a source, go to someone that you think has some wisdom and can give you some insight. There's so many resources online, so many communities who are on Instagram, on LinkedIn. And I know if you shoot them a DM and say, hey, is this real? I read this. I'm not sure. Man, as you do your own research, really do make sure it's credible. But I think it will stand to help you feel more empowered when you go into conversations with providers. They're not the only ones giving you information. You actually have something to offer too. You have a lot to offer. And I think recognizing that is super important.
Very powerful. Just as you mentioned, there are therapies available, and sometimes the doctor may not be aware, and sometimes if they are aware, it's just not being offered.
I think first things first. If you are living with sickle cell disease yourself, or you have a loved one that has sickle cell disease, the first thing is identify the community-based organizations in your state. Those community-based organizations I recommend them because oftentimes in the sickle cell space, we all know each other and we all know of each other's work. And I think as a patient, I always share my personal story that I didn't come out and share that I had sickle cell disease till I was 28. And I waited so long because being Nigerian, it's a highly stigmatized, weaponized disease. And so my family always told me, sharing I had sickle cell felt like airing our family's dirty laundry. So it wasn't until I was close to my deathbed with Mac that I reached out to an advocacy organization on Instagram. At the time, they were known as Bold Lips for Sickle Cell, that I got involved in this style of community work. Anyone can be an advocate. Anyone can advocate yourself. But if you don't have the knowledge, you are not properly equipped to be able to chime in on conversations with your provider and your care team, or find a well knowledgeable sickle cell clinic or sickle cell center of excellence that can offer you care. So I think connecting with the CBOs are important because they'll do two things. Most CBO organizations have a board of directors that often consist of providers in that local area that are the most knowledgeable, that have a decade long, if not more, of career in hematology. And when I say hematology, I mean specific to sickle cell disease, because oftentimes when you say hematologist, oncologist, it's not every time you're going to be met with a provider who genuinely cares about sickle cell.
Right.
Oftentimes their focus is more cancer, and sickle cell is just like that one part of their work where they have to pay attention to, but it doesn't bring them any kind of joy. So I think connecting with your CBO organization is the first way to even get access, because your CBO will let you know, here are some of, in terms of these ever evolving and changing landscape, here is what is available to you, and then connect you with the provider who can then escalate that conversation to the nurse coordinator or the patient engagement navigator, to be able to see, is this treatment option relative available for you? And if it's not, what state can you travel to be able to get these new treatments? I even think when you even talk about access, right? Let's start from the foundational piece of disease modifying therapies. Transformative therapies is not for everyone. If the eligibility criteria is you have to have had at least 4 hospitalizations a year, not for vaso-occlusive crises, a hospitalization that requires admission, a red cell exchange, and pain management. If you do not meet that eligibility criteria, they wouldn't even consider you for these transformative therapies. Another thing to note is, right now, gene therapy and transplant are just approved for HBSS, which is
Mhm.
the most severe type of sickle cell disease. Christelle has SC, and she's only one of 2 patients I've ever met in my 8 years in advocacy that have been able to participate in a transplant, because they don't look at the other phenotypes of sickle cell disease as dire or severe. So I think for many patients, I always say start with the foundational piece of disease modifying therapies first. And hydroxyurea today is not the only one.
Really, really rich content from Wumi Bakare and Christelle Salomon, hosts of Through the Genes podcast. Be sure to subscribe, like, and follow. Thank you for being a guest on Genetics for Healthcare.
Thanks for having us.
Thank you for having us, Rome. And I just want to say this. Love what you're doing with your show. It takes a very intentional and astute person to see need and fill that gap. Um, you have a background in pharma. You could have stayed in pharma and not explored these types of conversations. But people like that look like us know that no matter what industry you're in, there are corporate politics that you're having to navigate, and a lot of redlining and like red tape. And so I really do think that championing a show like this and featuring patients like us, not only is it imperative, but it is appreciated, because oftentimes in the sickle cell space, we don't always feel supported by industry, because sometimes it feels far removed. But you are doing the heavy task of kind of bridging both industry and patients and really serving the patient community. And so for the work that you're doing, I just want to say thank you so much for seeing us. It's one thing to recognize that we exist. It's another thing to truly see us. And I think on your show today, you have seen the women behind the show, and gotten to better understand the method to our madness, right? Like why we move the way we move is because a lot of our lived experience and our past trauma evokes the work and fuels the passion that we do today. And I'm hopeful that this will end with us. I'm hopeful that you will open the door to even younger generations of warriors that are born with sickle cell disease, that are exploring transformative therapies, because I think no two patient stories are like, I always say sickle cell warriors were like fingerprints. You can see twins with sickle cell and the way it manifests is vastly different. And so I'm hopeful that now that you've opened the door to us and our little show, that you'll also open the door to 16-year-olds, to 13, to the next generation of patient advocates who are doing really phenomenal work at a middle school and high school level. But I just can't imagine where their career is going to end with all of the work that they're doing in this space now. So again, that's just my long way of saying thank you.
Oh, you honor me with your presence and your words. So thank you. Thank you very much for your efforts and what you're doing. So like one of my partners say, we all we got.
This is Genetics for Healthcare, a podcast for patients.